Welcome back to Morning Live, and the month of March is actually the endometriosis. Actually, it's called. I think I'll be corrected that because the month of March. The name is kind of very tricky. Endometriosis Awareness Month, and with me in studio is our fertility expert, that is Dr. Kireki Omanwa. He'll be telling us more about the condition, and trust me, as it is, we were talking behind the scenes, it's really taking a toll on so many women out here. Karibu sana daktari.
Asante sana.
Good to see you.
Yes,
thanks for coming.
Yes.
The month of March is here. Endometriosis is actually very detrimental, kind of really taking a toll on so many women, as I've said. Now maybe you can define for us, what is endometriosis?
First of all, thank you very much, Nick, for inviting me here. And it is good that we are doing this talk about endometriosis, which is a big problem.
Sure.
And quite a number of ladies don't know about this problem. And most of the time they get diagnosed quite late when we may not be able to help them very well. So maybe I can start with the definition of endometriosis. You see, when ladies have a period every month, what basically happens is that there is a lining in the womb, which is called the endometrium. So normally, if a baby has implanted, the baby grows, attaches itself on the endometrium. So every month, if there is no baby has attached, that lining comes out. So that is the endometrium. Now, if we get a piece of this endometrium, this lining, which is active in another part of the body, it can be on the ovaries, it can be on the tubes, it can be in a place what we call the pouch of Douglas. It can be on the large intestine, small intestine, and rarely do we find it in other parts of the body. For instance, in the lungs, in the nails even, sometimes. Very rarely do we find it in the brain. But one of my senior colleagues actually at the university said he's seen 1 or 2 cases of endometriosis in the nails and even in the brain. Now, somebody may ask, so how do these tiny pieces of this endometrium, which is active, by active means that it responds to the different hormonal changes during the normal cycle in a lady. There are different theories about how this piece or pieces of tissue can actually get to these different places. The first theory is that instead of the blood coming out, the menstrual blood coming out, that menstrual blood can actually go back, what we call retrograde menstruation. And this can explain to a certain extent why we do find pieces of this endometrium on the ovary or on the tubes, for that matter. There is another theory whereby they say because this piece of lining is very sensitive and it irritates other tissues around it, and they undergo what we call metaplasia, a change. And that can actually account for the presence of this lining in places what we call the septum, recto-vaginal septum, where the rectum and the vagina almost meet. The issue of this endometrium being, for example, on the scar tissue after cesarean section, or even after what you call an episiotomy, when a lady is delivering, sometimes you make a small cut around the vagina so that to facilitate the baby to come out. So sometimes that tissue can actually stick there. It can also stick around the scar post-cesarean section. So that is what we call direct implantation. Now, there's something else as well. This is a theory about the immune system. Just like in Kenya, we have the army, we have the Air Force, we have the Navy, and so on. So if we are attacked by anybody from anywhere, so we all congregate and fight this enemy. So the same way our bodies have a system, a defense mechanism. So if this tissue happens somewhere, so the body congregates its armies and they go and try and defend this piece of the organ that has been attacked by this foreign tissue. And because of that, it produces a lot, the body produces a lot of chemicals, what we call interleukins, tumor necrosis factor, and so on and so forth, to sort of try and defend the body. And because of that, this can actually lead to a spread of that endometriosis. They try to to stop it, but then by stopping it, it continues growing in that place, and then it can also spread.
Now the symptoms, because some ladies actually, is it maybe one of them complaining
Yes.
of like painful periods? Really painful.
That is actually one of the classic symptoms.
Okay.
A patient will come and say, Daktari, I have an issue with periods. My periods are very painful. So the first thing we ask is, when does his pain start?
Okay.
Typically for endometriosis, the pain will start a few days to about a week before the periods start. And then they sort of have a maximum pain during the periods, and then they start slowly dissipating as the periods progress. And then they disappear after the periods, the periods end. And then the cycle keeps on, repeating. Some other symptoms that they come with that we ask in order to try and find out, because some patients can have painful periods, but does not necessarily mean that they have endometriosis. They can have issues with intercourse, for instance. So they say when we have intercourse, especially deep penetration, causes pain. When they go to open their bowels as well, sometimes they have very painful motion, or sometimes they can also see blood as well. In others where it has spread quite widely, it can also have what we call bladder effects. So you feel like you want to go to the loo for a short call, and when you go to the toilet for a short call, you feel like you don't finish emptying your bladder. You go back, and then after a few minutes, you also feel like wanting to go back. Yeah, and then there's also psychological impact as well, because if you have such painful periods, some patients actually need some very strong painkillers to help them make through this terrible period. And some of them, obviously, if sex is painful, you may not have intercourse. And if you're trying to have a baby, usually, having a baby, you must have intercourse. You should have intercourse. Though there are other ways of going around it. Yeah, but that can also be a problem.
Maybe other symptoms.
Yeah, the symptoms that I mentioned, those are the classic ones.
Yeah.
Sometimes they can also have a bit of lower abdominal pains as well. Some patients have vomiting as well. And some are so intense that sometimes they can even lose consciousness, unfortunately. But those are extreme cases.
Now, the risk of the condition, what are the risks the condition now offers to so many people out here?
Now, if you look at the incidence rate is generally about 10% of all women. We don't have a lot of data when it comes to this side of the world, because scientists used to think that Africans do not have endometriosis. And actually they could have been right, or they were right. Because if you look at our great-grandmothers and our grandmothers, they used to get married very early, at around 13, 14, 15, and they would start having babies straight away, So you have a child every 1.5 years, 2 years, and you'd have 10 children, 11 children, 12 children, and so on. So even if there was a hint of endometriosis somewhere, it would not be able to survive that. Because pregnancy per se actually makes the ovaries not to stop working, and by stopping working, even if there was any spot of endometriosis somewhere, it would not be able to thrive. So maybe that was the reason when they said Africans don't have endometriosis. But we have seen it now, and it is quite a lot, especially I see it in patients who are having issues with infertility. It is one of the problems. Now, in patients who have infertility, about 20 to 30% actually have an issue with endometriosis. So it is a problem which, that is why I said right at the beginning, it is good that there is Endometriosis Awareness Month, and we are talking about this such that ladies can know that if there is an issue, they have some of these symptoms, then the first port of call is to see a doctor. All
right. Painful, not even painful periods, missing your periods also.
Yes.
Is it one of them actually in this case?
Missing your periods, not necessarily, because there are some patients who have what we call polycystic ovaries, and those ones actually skip some of them.
What are polycystic ovaries?
Polycystic ovaries is a different topic altogether, but since you mentioned it, it is one of the problems which affects ladies who are between early 20s, early 30s. And in some severe cases, these patients actually have missed their periods, when we do a scan, we find that they are what we call tiny, tiny cysts. They are cysts, but they are not really cysts in a proper definition of a cyst. So these patients have issues with the irregular periods, they have issues with acne, they have issues in getting pregnant, they can have some hair on their faces, you know, typical for men, even some on the chest, and so on and so forth. They have big problems in getting pregnant. Some of them are obese, and they have also issues with diabetes and so on and so forth. So as I say, that is a different topic altogether. It is quite wide, but having missing periods does not necessarily mean that one has endometriosis.
Diagnosis, a very important actually part of this.
Very good. Number one, the first thing we have to do is to listen to the patient. When the patient comes, when you ask these questions, there are several questions which you need to ask to find out. That is why the first question which I ask a patient is, when was your first period? When was your last period? How are your periods? Are they regular? If they are regular, how often do they come? They come after 28, 30 days, and so on. How long do they take? And then the next very, very important question that actually helps us to sort of have an idea about what is happening is, tell me the characteristics of your periods. Are they heavy? Are they painful? Do they have clots? And so on and so forth. So the patient will tell you, Daktari, my periods are very painful. Say, if they are painful, when does the pain start? The pain starts around 3 to 4 days, sometimes even up to a week before the period. And when is the maximum pain? Is during the period, when the period starts. And then after that, what happens? The pain starts dissipating. So this leads you now to the other questions. Do you have any problems with intercourse? Do you have problems with emptying your bowels, emptying your bladder, and so on and so forth? So this can actually give us an idea about where we are going. So number one, the medical history, very, very important. Number two, if they've had any surgeries, because a patient will come and tell you, Daktari, I've noticed something around my my belly button, and this something swells, especially during my period, and then it becomes softer after my periods. So that one also gives us a hint. Have you had any babies? Yes. Sometimes I have somewhere where they cut me, what you call an episiotomy scar. There's something there which swells. These are some of the basic things that we have to ask. Now, if the patient has never been pregnant, has never delivered, then ideally the gold standard of diagnosing endometriosis, after we have taken the medical history, is something we call laparoscopy, diagnostic laparoscopy. What it basically means is that we have to take this patient to theater, make a small incision around the belly button, about 1 centimeter, put a camera inside the abdomen, and then have a look around it. And there, that will be typical. If they are what we call endometriomas, that is cysts which have endometriotic, we can actually see the way they are swollen. They used to call them a chocolate cyst. They still call them, but that can be misleading because other cysts can also have some brownish blood in it. So we call them endometriomas. When we look inside and around the bladder, and in the space which I told you called the pouch of Douglas, you can see some bluish, grayish, sometimes black spots. Very, very typical as well of endometriosis. Something else which I have to reiterate here and underline is that the extent of the disease does not always equate to the symptoms. We may put a scope inside the abdomen and we find the disease is quite spread. But then the patient does not have symptoms, or he has very minimal symptoms. So
how is it that much spread and maybe there's no symptom? Or maybe
now that again depends on the penetration, how deep the disease has spread. If the disease has penetrated more than 5 millimeters of tissue, then the symptoms are more. It can be superficial and it looks horrible, but the penetration is very, very little.
Treatment in this case?
Treatment is quite varied, and again, it depends. It depends, number one, on the extent of the symptoms. It depends on what the patient wants, and so on and so forth.
Well, there's also options here.
There are very many options. There is conservative management, whereby the pain is there during the periods. Young lady, not intending to get married, or if she's still in early secondary school, doesn't want to have a baby, and so on and so forth.
Oh, so it affects all the ages?
It affects, actually, one of our postgraduate students did a study in one of the secondary schools, and he found that it affected about between 20 and 30% of the young girls who had just started school. But you see, okay,
so it swipes all through.
It swipes all through. Even though this was just a questionnaire which he gave them with endometriosis-like symptoms. So in order for us to actually confirm that that's the way it is, we'd have to subject these young ladies to laparoscopy and to make sure, okay, this number 1, number 2, and so on and so forth, have actually endometriosis in themselves. So there can be conservative management, where we give the patients painkillers, and if the pains are not too bad, we can use hormones.
You mentioned laparoscopy.
Laparoscopy. Yes.
Wow, interesting.
Laparoscopy. That is basically putting a camera inside the abdomen. What we call keyhole surgery. So we put a camera there, we have a look. If there are any issues to be sorted out, we can actually sort them out. And it is one of the best ways, actually, and it's the gold standard of diagnosing endometriosis. But again, in this part of the world, again, we have a problem because number 1, we don't have enough specialists. Number 2, we may not have equipment. Number 3, accessibility is a problem. So you can imagine a patient who is, let's say, in the northeastern, in Wajir or Garissa, or even in Migori, or whichever, Samburu and so on, where they may not have access to actually people who are trained to do laparoscopy. So that becomes a big problem. So that is one of the biggest bottlenecks that we have. However, there is a way which we have come up with, there is an International Endometriosis Society, which came up and said, look, in places whereby accessibility to laparoscopy is a problem, we can actually diagnose this indirectly by doing what? A patient comes and gives you all the symptoms that I've mentioned, and you have a 75, sometimes even 80, even 90% chance that this patient has endometriosis. We can actually give them some medications. So we give them these medications for 3 months. If the symptoms disappear in those 3 months, it basically means that it was endometriosis and the diagnosis was actually right. All right?
Now, when you talk about cancerous cells,
yes,
is it actually just a pre-cancer, or you know, there's so much that happens within the cancerous cells? Can it really lead you to cancer in this case? Very
rarely does it do so. Very, very rarely. But the mechanism, it does not metastatize, as it were.
So it doesn't recur. Does it recur?
It can recur. But what we are talking about metastasis is that there is a center somewhere, a small source somewhere, which has a problem, and that actually keeps on doing what is called seeding. So it sends out those abnormal cells to other places in the body. So that one, people have thought that it can be similar to cancer, but it's a big debate about it.
Does it affect men?
No, it doesn't affect men because we don't have a womb.
Absolutely. Thank you for that. Thank you for that. And then something, unless you have a womb at home, I don't know.
Which you can borrow from.
Just a question from someone. Anyway, now someone also was actually wondering now.
Yes.
The fertility stories, the fertility issues.
Yes.
Barrenness and everything.
Yes.
Does it cause barrenness?
It does cause barrenness. It does cause, because if it is extensive, number 1, it affects the ovaries. Remember, I said that the first most prominent place where it attaches to are the ovaries. So this tissue will actually behave exactly the same way as the lining in the womb. So it starts growing during the cycle, it reaches a maximum, and then once the period starts, the size sort of decreases. So if it is on the ovary, it will react in the same way. It's a small tissue there, it will expand, and then it will deflate a little bit. So with time, more and more of blood is accumulated. So what we call an endometrium, which can be anywhere between 1 centimeter to even 10 centimeters and so on. What we are worried about, number 1, is the bigger it is, the more it will destroy what we call the ovarian tissue. And ovarian tissue is where we have the eggs, potential eggs. So it actually does destroy that. So you may find a young lady who is 20-something or even early 30s. When we check her ovarian function tests, we find that it is very low. So the next thing you ask is, have you had any surgeries? Yes, I had surgery. What was it? Well, I had endometriosis. So then there you go. So if the ovarian function test is very low, it means what we call the ovarian reserve is low. The chances of her getting good eggs on her own is also reduced. So that causes that. It can also cause infertility by when it spreads to the tubes, it actually makes the tubes non-functional. So at the end of the tubes, we have what we call finger-like projections, we call fimbriae. And these are the ones which actually pick the egg once it has been released. So if they are stuck, there is no way they can be able to pick the eggs. Sometimes it causes the tubal blockage as well. So if that happens, then obviously it's going to be a big problem. And then there is the immune aspect as well, the one that I mentioned, that the body sends soldiers to go and sort of try and stop it. By doing that, what basically the body does, it activates the immune system such that even if we were to get somebody wanted to live inside the womb, that is a baby is basically a foreign body. So the immune system will be hyperactive, and it will actually know that there is somebody who is something which is foreign here. So let us attack it as well. So that is also an aspect of infertility as well.
The cost of treatment, you know, we have to touch on that because someone has a problem, wonders how she will maneuver through the cost.
The cost is, again, it depends. It depends if the disease is caught early, if it's treated well, and so on and so forth. As I said, the best, number one, the best method of diagnosis is laparoscopy, which can also be a bit expensive, but thank God we have NHIF, which actually does help. It offsets some of the costs of treatment. The bigger problem becomes when we have spread, when endometriosis is quite spread, and when we have what is called a frozen pelvis, where all the structures inside the pelvis, that is the womb, the ovaries, sometimes even the bowels, are all stuck together. Then it becomes a very big problem because operating laparoscopically means that one has to have a lot of expertise in doing that, and then you will also need other experts to come in and help you, because you can separate some things to a certain extent, and depending on the extent of the disease, sometimes the bowels are stuck together. Sometimes you may need to actually do what is called a resection. You cut the bowel, and then to remove the deceased part and then suture it together, reattach it together again. Now, doing that laparoscopically is actually a tall order, meaning that you have to have a lot of expertise. It's an ability which is not easily found in this part of the world, and that can actually be a problem. Last week, I wrote a letter to one of my patients who have actually been suffering for the last, I think, 7-10 years. And when she did an MRI, we found that they were called what we call nodules on the rectovaginal septum, and then the whole pelvis is actually stuck together, what I call frozen pelvis. And she found out that there is a center somewhere in Europe which can actually do that. I worked in such a center in the UK. We had what we call a center of excellence. So patients who had issues with endometriosis would actually come to that center. And the gentleman I was working with actually would do a lot of surgery, laparoscopically. It's long surgery. It takes 4 hours, 5 hours. But then he would have another surgeon there who would be able to, in case the bowel needs to be resected, we would actually resect it and then suture it laparoscopically. After 2-3 days, the patient would go home. So that is an issue which we need to take up, to actually have centers of excellence where people with top expertise can actually come together and work in a multidisciplinary team to help these patients.
From research, has it been proven maybe if it's genetically a condition which is kind of affecting people from the same kin? What do you think about it?
There is an angle to it. There is no proven gene that if you have this gene, then you have endometriosis. Like, for instance, breast cancer. We know that if your parent, if your mother or your sister, grandmother has the BRC, what we call BRC1, BRCA1 or 2, then the chances of you having that breast cancer is also very high. We don't have a gene which says, okay, if you have this type of gene, then the chances of you having endometriosis is high. However, there is a connection. The first line, what we call the first line connection. If your mother or your sister had endometriosis, the chances of you having endometriosis is about 6 to 7 times higher than the normal. So it's an indirect way. We don't have a direct way, but yes, there is that linkage.
So finally, before we wind up, as a fertility expert,
yes,
something else very different. Male contraceptives are being tested. The gel actually in your shoulder.
Yes.
What do you think about it?
I think it's a good thing, even though actually it's one of my colleagues who is the principal investigator, Dr. Kinyua, John Kinyua,
sure.
and we are trying to do that. It's a small group. I saw the write-up. It's a small group, but I think it's a step in the right direction.
All right.
Because contraception has always been
on the
brand
side.
has been always been sort of sorted out or sent to the women. Will it work? I don't know. We'll just have to wait and see. Because even with the condoms, is also a problem. Because there are some gentlemen who can't use a condom at all.
Wow.
So we just have to wait and see. And then again, I think there is a cultural aspect, there is a social aspect, and so on.
All right.
That is the ladies who have always used contraception, so why should we start using contraception now? But I think maybe with time, once people get used to it, get used to that idea, that actually this contraception do not make you impotent, they only stop the activity of the sperm or the production of the sperm.
Vasectomy is what now makes you can completely
Vasectomy, again, it's not 100%, but most of the time it is, most of the time it is.
But I believe, I think it's cutting.
We cut it. That is why you call it Tommy.
I think that's 100%.
We cut it. But sometimes rarely does it happen. They can rejoin again.
Wow.
But very rarely does it
interesting.
happen.
My body is a very interesting thing. Thank you so much, Doc, for coming. And of course, I have to release you. You told me you have a surgery.
Yes.
Absolutely. Now, thank you so much for making time, for coming to the studio.
Yes.
And I believe so many people have learnt about the condition, endometriosis.
Yes.
It's the awareness month, the month of March. So please, at least, keep vigil out there. Of course, we've learned so much. My name is Nick Mudimba. That's where we end the show. Jason Moon is coming up next with Full Circle. Stay tuned.